Yeah, so that kind of gets at having universal health care, but not universal access, right? One of the things when I was reading through, for those who found a country that did have a universal healthcare system, they typically had the physicians made less money, but the health outcomes seem to be a little bit better or the same as the U.S. Who did you have, Seth?
Denmark.
Denmark. So you had like some very healthy northern people, right? Who did you have?
Portugal.
Ah, yes, I remember. So they were similar.
They're like similar, I think slightly better.
Yeah.
So they were about mid-range for a European country.
Yeah. Who did you have? France. I had a couple of people have France. What about France?
Israel, I think.
Yes, you were the one with Israel. And they were
They had a better life expectancy.
like, yes, like 83.
Yeah. Something like
I was grading today, so things are very fresh in my mind. Yeah, so I thought it was really interesting, and I hope you guys learned something too. And that assignment's going to be like revamped in one of the courses, and instead of you guys just turning it in to us, you're going to present, not you, the future yous are going to present it in like a PowerPoint presentation and put it on a discussion board so everybody can learn all about the different countries. So, any questions before we start? Okay. Was it, you were the one, did you get the gold star for finding the problem with the link? Who found Typhoid Mary?
Yeah.
Okay, so it's correct now. So now you guys can watch Typhoid Mary. It's kind of like bootlegged, so I just keep on looking for different YouTube, so you don't have to like purchase it from Nova. Okay, so today we are going to discuss health services professionals. What's happening next week? Exam? Yeah, so don't come here, right? So all students, online and on ground, will have access starting at midnight until 11:59 p.m. on next Thursday to take the exam. There are 30 multiple choice questions, multiple choice true false, and then there are 5 short answer questions. But here's the big but. You only answer 3 of those. So you pick your 3 favorite. If you answer all 5, we'll just grade the first 3. We're not going to, so do yourself a favor and don't answer all 5, answer 3. Now, I think it works out that the 30 multiple choice and the short answer are worth the same weight. Is that correct?
I think so.
So, short answer is not like a couple bullets or like nonsensical, not quite a sentence, not really thought out. Like write what would be 1/6 of your grade, right? Each one of those is that right? Yeah, 1/6 or something.
Yeah.
So it kills us. Short answer, that's like a misnomer. It's not an essay, long essay, but at least a paragraph, okay? And you have plenty of time to take this because it's open as if we were sitting here, so 2 hours and 50 minutes. You will not need, most likely, 2 hours and 50 minutes, and it's open note, open book. Okay.
So like an essay, like a short answer essay with a paragraph. Some people go, well, 2 sentences is a paragraph. No. You can't even develop your idea in 2 sentences, so yeah. Give us an introduction to what you're doing, talk about your
Mhm.
talk about why it's important, and then summarize it.
Make sure you answer all, like if it says, you know, what are the different types of universal health care systems and what are the pros and cons of each? Then you state which each one is and pros and cons for each one. Very, very easy. These are not hard tests. Okay. You guys are going to do great. Any questions on that? So you can do those at home. You can use your books. You can use your notes. You cannot use your neighbors. So try to take it by yourself. All right. So as I mentioned, this week we're going to talk about health services professionals, and then we're going to do an activity in class for those who are in class. So healthcare is the largest employer. So it employs about 3% of the total labor force in the United States. So it's not only the largest, but it's also one of the most powerful because it's about 18% of the GDP for the U.S. And it continues to grow. So why do you think healthcare continues to grow?
We have an aging population
Yeah.
that needs care.
Yeah, aging population. And as you get older, you tend to need more care. And not only is our population aging, but our population is also growing. So because there's the demand for services, that drives our demand for healthcare professionals. And the field is not just made up of MDs. I had an interesting week. My grandmother, who lives in Jonesboro, who moved here after I moved here because she loved the mountains so much, got ill and had to be taken to JCMC. And so she's at the hospital. She's fine. She's home. She was at the hospital. My mother's frantic. My uncles who live in Texas are calling, and I'm talking to one of them, and my uncle says, I want her to be seen by a doctor, not just a nurse. I said, oh, okay. Well, she's going to be seen by, the attending physician, but there's nurse practitioner. I want to see a doctor. Okay. But really, the field is made up of not only, we're going to talk about tons of different healthcare professionals, but it's not just your typical MD anymore. We have tons of different healthcare professionals, including what the book calls physician extenders, which are what we think of as nurse practitioners and PAs. So lots and lots and lots of different people, and we'll talk about them in detail. But where they're housed or where they work is predominantly in hospitals. So 40% work in hospitals. The next largest chunk is in nursing and personal care facilities. And then about 10% are in physicians' offices. So we can see, this is hard to see on this screen, but this is a table in your book, and it's showing, excuse me, the distribution of different physicians or different employed persons at different sites. So these numbers are a little bit different than on the previous slide. They've changed, well, they've gone, they're a little bit different, yeah. Instead of 10% in offices, it's 9.4. So these were updated for 2016. there's lots of different places as we talk about kind of the change in healthcare, moving away from just your traditional brick and mortar hospital to outpatient care. You see the providers moving into these other sites. Lots of work in outpatient care, home health services. We're going to see that continue to grow as well. So physicians, when we think about healthcare providers, that's really the two big groups are physicians and nurses, right? So physicians are the ones that play that vital role or central role in evaluating patients. And as Mr. Youngblood talked about last week, we moved away from mom and pop medical schools to the requirement for licensures, accredited medical schools, in addition to 4 years of medical education. They will complete a residency, which is really an extension of their education, but they're paid for it. They're paid a little bit of money for it. And depending on where they're going or what they're going to do, it's between 2 and 6 years. And what we've seen over time is that the number of active physicians has increased. And we'll talk a little bit about how that has increased and how that looks based on specialty versus primary care. But there's two main types of physicians. They both use accepted methods of treatment, including drugs and surgery, but they differ in their philosophies and approaches to medicine. So your MDs are your doctors of medicine, and so we have a college of medicine here that graduates MDs. And so this views medical treatment as an active intervention. So just think about what we talked about on week 1, this idea of the treatment to counteract or neutralize the effects of disease. And when we look at the distribution of MDs and doctors of osteopathic medicine and DOs, we see that more MDs are specialists. DOs emphasize in their training more the muscular skeletal system of the body and its correlations to joints and tissue. But I should stress, because we had a DO in our class last year, their training is very similar. But again, this philosophy is different. And they're more generalist, our primary care providers.
I think that's just as a whole.
As a whole.
Yeah, because I have a close friend of mine. He's a cardiothoracic vascular surgeon. He's a DO.
Yeah.
So it just depends on your route. So.
Yeah, because if you're going to go into cardiothoracic surgery, you're going to be in school for 1,000,000 years. Anyways, it does that first 4 years. Your residency is going to be another 6, and you're getting the same training as anyone who's going to be a surgeon. So osteopathic medicine, again, is practiced by DOs. Stresses preventative medicine, diet, environment, other things. Takes a holistic approach. They only make a small portion of our physicians. I would say this is a growing, though. I feel like I see more and more people going into osteopathic medicine, or their schools are growing. We're seeing more osteopaths, I think, in Appalachia as well. And there's some schools in Ohio. There's a really good school in Ohio that I know of that trains some osteopaths. So, any questions about DOs versus MDs? Okay, so as I mentioned, we were talking about DOs are more generalist or primary care, MDs more specialty care. So what what does that kind of mean? So primary care physicians are generalists. They're trained in family medicine or general practice, general internal medicine, and pediatrics typically. They provide preventative medicine. So when we think of preventative medicine, we're talking about exams, immunizations, mammographies, pap smears. And they typically see patients with problems that are less severe and less frequently. But that care is longitudinal in nature. And then specialists fall into pretty much everyone else. They make up about 65% of the physicians in the U.S. compared to 35% of primary care. And now if you're looking at this compared to other countries, this is an imbalance. Because most countries, their specialists make up less than 50%, somewhere between a quarter and 50%. So to be a specialist, your training and residency is longer typically. And you have to seek additional certifications for that specialization. So here is our 6 functional groups of medicine. And you can see that our largest, these are our non-specialty groups, except for obstetricians, gynecology. What's interesting about that is if you were to ask different people, they would probably give you different answers as to if OBGYNs are considered primary or specialty. Why would you think you might get different answers to that? And we have more men in this class than women.
I would say because it's the preventative service
Yeah.
that you're going to regularly.
Yeah. Unless you're pregnant, you're not trying.
True.
But yeah, so it's preventative. So you get your annual exams for women. Which include pap smears. They do cancer and STI screenings. Another reason is for many women, younger women, their gynecologist or OBGYN is the primary doctor that they see. That's the one they have that longitudinal relationship with, that they see on a regular basis. They may not, they may have a primary care physician, but the person that they see for various reasons is their OBGYN. Okay. So just diving a little bit deeper into primary versus specialty care. So your primary care is usually your first contact with the healthcare system. They're considered gatekeepers, and when we watch the video, how do people typically feel about gatekeepers in general? Doesn't matter what country you're in.
Michael.
No. But we, most of our insurance is through managed care organizations, and they use gatekeepers a lot, and so they are the gatekeeper. So you typically will see a primary care physician, and they will refer you to a specialist for different ailments or issues. So again, you see the primary care, that's your first contact. Specialty is typically seen after you've seen your primary care. As I was talking about, primary care is longitudinal. Specialty is episodic. You typically are going to see a specialist for a very specific, focused, intense reason. You may be seeing a cardiologist because you had a heart attack, and so you're seeing them for that. You may have pulled a muscle, broken an arm, so you're seeing a orthopedic doctor for that. But typically, once that issue is taken care of, you're not going to be seeing them that often. And so primary care is time spent in an ambulatory care setting. What is an ambulatory? What does ambulatory mean? Not typically. I think you're thinking of, I can't say the word, ambulance. But what is the word ambulatory? What's the root of that? We don't have English majors this year. Amble, or walk. So it's in a community setting. Versus specialists, who are usually in an inpatient hospital using state-of-the-art technology. So it's not as close to the patients. Any questions about the difference? I think it's pretty apparent. So there are quite a few issues that we see in medical practice that kind of make this work interesting or add complexity to medical practice. So, clinical practice guidelines. Do you think these are static? Do you think that we've got the guidelines and that's how we're going to do it? No. They evolve, which can sometimes be difficult for people. Because you, as you get used to doing your work, you get comfortable with a certain set of guidelines or practices, and that's how you like to practice your medicine. But we're seeing more and more involvement in clinical practice guidelines. We've seen some updates recently, some that have been a little bit controversial around screening, mostly lessening the amount of screenings done or the age that certain screenings should start happening. So a couple examples are Pap smears and mammographies. So there have been changes in the clinical practice guidelines. A lot of these are due to the best evidence that we're getting. So they align with research, but it's hard to tell physicians to not screen women of X age for mammography if that's what they've been doing forever. And actually they've seen that screening produce early interventions or early identification of cancer. So that one was a really hard one. Pap smears is another one. If you haven't had a abnormal pap, then the frequency is supposed to go down, not every time you go for an anal exam. So that those are based on research, but often they're also based in costs. So both of those examples are decreasing a service, which is a cost. So there's a lot of weighing what a physician or a provider would consider best practice with the cost and having to justify that. And that's really where we get into this professional or threat of compromise. So physicians and providers, not just physicians, have to, again, justify what they're doing to not just their patients, but to manage care and like different financial arrangements they have. So many things have to get pre-approval, and so the provider has to seek and justify a test before they can do it, even if that is, in their opinion, the best course of action. So another issue is lopsided medical training. So what do we mean by lopsided medical training? What do you think this means?
Differences in like the quality of education of physicians, depending on.
So no, I mean, just as Mr. Youngblood said, the student at the bottom of the class in med school who still passes is still doctor, right? So I think across the board, education is good. We actually have the best medical training in the world, but we have a lot more specialists than generalists. Why do you think that is?
Well, the specialists make more money.
Make more money. That's one of them. So, do we charge specialists more money for medical education than generalists? No, they pay the same amount, which is not a small amount of money, right? We know that, compared to Germany, medical education is free. That's incredible compared to what kind of debt our physicians are coming out of school with. So when you're weighing that, and you're looking at, and I'm sure you guys are going to do this math in your head when you graduate. You have some student loan debt, and you have some options for careers and different places to work. That plays a role in it. And so it kind of leads this oversupply of specialists. And so these kind of actually the 4 through 7 all are kind of mixed in together. So we have an aggregate oversupply of physicians. So we have a lot of people who want to be doctors for lots and lots of reasons. We've had an increase in the number of physicians of over 173% from the 50s to the 90s. In 1997, the Balanced Budget Act of 1997 capped residencies for that Medicare pays for. So Medicare pays for the lion's share of medical education, so the residencies. So they capped it at $7 billion a year, which was about $70,000 per resident. So they don't say like these residents need to be trained, like 50% need to be this and 50% need to be that, or 20. There's no like mathematical equation that the government's saying we need certain types. So it can be trained in any of the specialties or in any general medicine. So even though we have this oversupply, we've had this cap. And so that cap has led to this shortage in certain parts or maldistribution of physicians, both from a geographical perspective and a specialties perspective. And so we aren't really making decisions on who we're training based on the need. Again, because there's no cap on the types of physicians. So one of the major issues is geographical maldistribution, and your homework number 3 is related to this. What we have is a shortage of doctors in areas with population less than 50,000. Why do you think that is? What are some of the reasons? And you'll read a lot more about this. But what do you think are some of the reasons why we don't see a lot of physicians in areas that are less densely populated?
You make less, and there's also like inconsistencies in the demand of care.
Okay, so you make less. There's possibly less demand or inconsistencies. What are some other reasons? Yeah. So where are medical schools typically located? Urban areas. And then where are residencies typically located? At med schools, right? Yeah, so in urban areas. And so you get trained in these state-of-the-art programs using all these great equipment. Those are used to recruit physicians to those residencies. And then you go out and you're given an opportunity to go anywhere you want. And you end up in a community with less technology. And maybe less access to facilities too. So you're doing medicine in a different way than you were trained. And we Americans love our technology. Even as professionals like the technology. It helps you do your job. That's what it's there to do. What else? What are some other reasons why providers may not choose to live in rural or less densely populated areas? Why do people in general leave rural areas? Because physicians are just like us, with more
Nothing
debt.
there.
Huh?
Quality of life.
Quality of life. What about quality of life?
I guess there's more just various opportunities in an urban area.
Yeah.
Work, social.
Yeah, social. You're finally out of med school. You're finally out of residency where you're slogging, working, 24-hour shifts. You're ready to relax and have fun. So the cultural opportunities are different than in an urban area versus a rural. What else? Schools. You're out of school, but you may have a family by the time you finish your 10 years of schooling. And you're looking at schools, you're looking at providers, so colleagues. Like if you're one of only a few physicians, you don't have that camaraderie, that ability to bounce things off of your coworkers. That's a big part of medical education, is working in teams. You might feel a little bit isolated.
Taking call.
Huh?
Taking call.
Taking call. Yeah.
Making sure you have a base to cover your. You don't be on call every weekend, right?
Yeah, you have to have colleagues. I have a colleague a rural researcher that I work with a lot, and he used to live in Bradford, Pennsylvania, which is in rural Appalachia, and they had one obstetrician, and when he died, they were like, "Who's gonna deliver all the babies now?" And do you think he got a lot of vacation time? Probably not. Babies don't seem to care. So there's a lot of things that may impact where somebody decides to practice medicine. What are some things, and this is something that you're going to be tasked with for your homework, but what are some things that might increase the likelihood of somebody wanting to go live in a rural area?
You don't have a lot of competition.
Yeah. Yeah, you wouldn't have a lot of competition. If you're in your own, if you're not working for a healthcare system, and you're your own boss, yeah, you have lots of patients. They may be sick. They may be covered by lower coverage insurance, but you'll have lots of them. What else? What are other things?
Your like money goes further, so if you're buying a house or something.
Yeah. Yeah. You can get a lot of house here versus St. Louis. When I moved here, I was like, wow. Cost of living is lower. Places like East Tennessee, if you are someone who loves the outdoors, who like the things, the mountains, outdoorsy things, this could be a place for you. What else might? One thing that we talk a lot about in the area of Appalachia and rural America, but more focused, the work that I've done on in Appalachia is around the kids from the communities, getting them to think about that they could be a doctor, and that they if they like science, if they like math, if they like health care, to help support them to go to med school, because if you are from an area, you're more likely to go back there. So really kind of like from a grassroots perspective, like changing that dynamic where it's not just affluent people who are going to med school. So a lot of this specialty maldistribution and geographical kind of are interplayed. So as we saw, 65% versus 35%. 65% specialty versus 35% primary care. So since 1978 or 79 to 1990, so in a 30-year time frame, we had an 18% increase in primary care physicians and 118% increase in specialists. It's like a huge difference, right? So, very similar kind of things at play. So we already talked about the fact that you pay the same amount of money for med school, regardless of if you're going to be a primary care physician or a cardiac thoracic surgeon. What are some other things that might lead to this 18% increase versus 118% increase. I mean, when we think about that, that aggregate oversupply is all specialists then, right? What are some of the things that may be leading to that? Money, yeah. But people go into medicine to help people. Right? True. In that, especially helping people in that. They mentioned technology. Do you think that plays a part in it? When you go to your primary care physician, do they have a lot of fancy equipment in there? No. When you go to see a surgeon or a specialist, they have the kind of cool technology. They get to do kind of cool, gritty things like surgery and trauma and fast pace, or dermatology. That was a big thing. When I was in graduate school, we, in our College of Public Health and our College of Medicine, we worked closely on a program that did sun protection outreach to middle school kids. And so it would be taught by public health students and MD students. And public health students, we were doing it because we liked the t-shirt, we liked to, you know, it was a lot of community health students like to do the behavioral health stuff. The med students, if they did the program, they got to shadow a derm for like a certain amount of time. So there were a ton of med students that were involved in this program. And I was like, I didn't know so many people want to be dermatologists. Why do you think a lot of people want to be dermatologists?
Dr. Pimple Popper. That's what kind of made me want to do it.
Dr.
I'm one of those
Pimple.
weird people.
So Dr. Pimple Popper was not in existence. Well, she probably was, but she wasn't a celebrity or internet star at the time. But yeah, so for that reason. What other reason? Cosmetics. How many dermatology emergencies happen on nights and weekends? Yeah. Never. You can get your mole surgery done during regular business hours, right? So there's some things about life, work-life balance, right? Different fields. You may pick a specialty for that reason. And then, since we have this imbalance of oversupply of specialists, do we see a lot of specialists in rural or sparsely populated areas? No. We have a hard time, even in the Tri-Cities, which has this great healthcare system. We have Ballad, we have the VA, we have Niswangers, which is part of Ballad. We have a hard time getting specialists to come. My husband used to work in internal medicine, and they got this really great allergist to come. He's no longer here. So in the time we've been here, he's not here. He couldn't get enough patients because there's just not the volume for some specialists. So since we don't have that many generalists compared to specialists, and they don't want to live in rural areas, and there's a shortage in rural areas, the supply-demand kind of math is not there. Specialists are typically not going to be in a rural area unless they've been recruited heavily, and there's some sort of specialty, like something that's bringing them there. So one of the solutions that has come about related to both geographical and specialty maldistribution of providers is international medical graduates. So who or what are international medical graduates? What is an international medical graduate?
They went to school internationally,
Yeah.
weren't educated in the States.
Yeah, so what do they have to do to be able to practice medicine here?
Don't they have to
That's their boards.
You have to take some tests, yeah, boards.
and don't they have to do certain rotations as well?
Yeah, so they have to go through residency just like any of ours to be able to practice medicine. So this is something that's, so they take their, I think they're called steps, Ryan? Their step tests. They take tests to be able to get into residencies. So they have to apply for residencies just like any other medical student and get matched. And about a quarter of our residents in the United States right now are international medical graduates. So it's a steadily growing area. So as I mentioned, we have the best medical training. So a lot of people want to come here and practice medicine for all the same reasons that we have an increase in physicians in the U.S. Where do international medical graduates typically move to? Like, where are they practicing?
I would guess larger urban areas.
They are taking those rural positions. So they typically do residencies in rural areas. Or they take a position in a rural area that has a contract that's a certain time frame. Now, so we have all these international individuals who want to come to the U.S. Should we just, as the solution to this geographical maldistribution, have them all, like, say, if you're going to be an international medical graduate, if you want to come to the U.S., you have to practice in a rural area? I think that would solve our problems. Why?
It's just one part of the old system, here for international medical graduates. It will make a difference.
Yeah, it will. So we will get. So this is kind of like the life cycle. So an international medical graduate will take a position in a rural area. After they fulfill their contract or they finish residency, what do you think they do? Leave. So then you have to fill them again. And it's this cycle. Why do you think international medical graduates aren't staying in our rural communities? And this is something that is like a real deal thing, especially if you're going to stay here. They are vital. If you talk to anyone who's doing physician recruitment at Ballot, international medical graduates are vital to meeting a shortage of physicians. But what are some of the challenges for communities?
culture's probably not as accommodating.
Yeah, culture. I mean, think of the difference. I mean, many of us we're in classes and are in classes with a more diverse group of people than we were in high school and maybe even undergrad. And it's such a, I think, critical thing and a great opportunity to have this diversity. But there are challenges for both, for the physicians and providers and the community. So culture. What about culture might make it difficult? Come on, let's get uncomfortable. What about rural culture might be difficult for someone from another country?
There's more racial prejudice.
Racial prejudice. Yeah, so if your doctor is racially or ethnically different, what else? We have international students in our classes. They have beautiful accents, right? Communication, though. They are our friends and colleagues in rural areas. They also have accents, right? So they're both hearing the same language, English, but spoken with accents, and that can be challenging. There's communication issues. And you're looking at someone that looks and speaks so differently from you. And one thing we know across the board is human nature is we feel more comfortable talking to someone that looks like us about our health. Women typically like women doctors, female doctors. One race likes doctors of the same race as them. The only exception, which is really interesting, and I haven't looked at the research lately, is African Americans trust non-African American doctors more than African American doctors. But they also don't. There's a lot of medical mistrust in minorities. But, if you're going to a community that already sees you as an outsider, that makes it hard because that's where you live. And there's probably not a lot of people like you either. So there might be some assimilation. So it's a part of the solution, but it's not the whole solution. Because you wouldn't probably move if you didn't feel like the community was supportive of you, or if you felt like you could do your best medicine or do your best job either. So we have to think about how to accommodate the community and the physician. Also, if every 2 to 4 years, a new doctor's coming in, that community and that individuals might not build a strong relationship thinking, well, in a couple of years I'm going to have a new doctor anyways. So there's a lot at play there. So these are just a very short little snippet of the issues that are around medical practice, that when you move on to your careers, you're going to be dealing with. And we're going to have you dive into the maldistribution, partially because I'm a rural researcher and I think it's really interesting, but it is a major issue facing healthcare. Just a little bit deeper, you have another consequence that we didn't really even talk about when we talked about too many specialists, is how that affects cost, right? So when we talk about it costs us more than other countries, like healthcare is a larger part of our GDP than our sister countries. This comes into play because we have specialists. Those that technology and those services they provide are more expensive. And so it creates this rise in healthcare costs. And surgeries, this is fascinating to me, grew at 2 times the rate of the population growth. So just think how that's impacting our cost. Okay, so we're going to talk about some other providers. Then we'll talk about, we'll end, so we're going to talk about other providers. We'll take a break and then do an activity when we talk about nurses, and then come back and finish up. So we don't have too many slides, but we do have an activity, and I'll put this activity online for the online students as well. So, dentists. Dentists are a really important part of healthcare and public health right now. Or not just right now, in general. But in rural areas, oral health is a really important and like emergent or epidemic issue. So dentists, their major role is to diagnose and treat dental problems related to your teeth, your gum, and your mouth. There are 2 types, a doctor of dental surgery and a doctor of dental medicine. And there are 8 different specialties recognized by the American Dental Association. So the support staff, or the support for dentists, include dental hygienists and dental assistants. Dental hygienists, they're the ones that do preventative dental care, clean, and they do education, and they must be licensed. And they're licensed and taught in this building. And you as students can get free teeth cleanings. Did you guys know this? I didn't know this until my husband's a grad student, and he was like, I'm going to get my teeth cleaned by the dental hygienist. I said, we have dental insurance. He's like, I know, I'm going to get 2 cleanings. So, can dental hygienists practice on their own? They have to be working under the care of a dentist. So, not only do we have a maldistribution of physicians, we have a maldistribution of dentists too, for the very same reasons. Now, a lot of what would help communities is having just the preventative side done early in childhood. Do you have the same insurance plan for dental as you do for your other health care? No. So it's a fascinating thing, because you get like your PPO or your HMO, and then you have your add-on dental insurance. So dentists have done a really good job of cornering the market. They've done, like the American Dental Association, ensuring that dental hygienists must be licensed, but they cannot work on their own, and that their care does not fall under this umbrella health insurance. They've done a good job protecting their industry. And so we see this maldistribution because the dentists are also not in the rural areas, and oral health is one of the top concerns in rural America. Why do you think it's up there? Drugs. Yeah, drugs. Poor education around dental care. My first year here, I got a grant to look at to do some research around childhood obesity, and so we were doing these focus groups across Central Appalachia, and we were in Kentucky, and we were talking about, it was about childhood obesity, but we were just talking about health in general and health of children, and this one individual, so these were community providers, so people who worked in the hospitals or in the public health department or in the schools. One of the women we were talking to said that she had a child come up to her, and they were talking about teeth. How many sets of teeth do you have? And the children believed you have 3. You have your baby teeth, your permanent teeth, and your dentures. So like that was just part of the culture because of lack of preventative care. I was like, whoa. We've got a lot of work, guys, around oral health. Okay, get off my dentist soapbox. I always
I'll tell you this, that's the best gig in medicine right now. It's the least regulated, so you have a lot more leeway.
Mm-hmm.
Set up your practice, go for it.
There is a dentist that does, in Kingsport, does laser to fix tongue and lip ties. So this is something that most of you won't know about now, but like if you're trying to breastfeed a baby and they have a tongue or lip tie, it's harder for the baby to latch, leads to a lot of problems. This dentist has this little laser for $450, which is not covered by insurance. She'll fix your baby's mouth. It doesn't bleed. Neither of my children need it, but I have friends who have been there, and she has a very beautiful practice. State of the art practice. And therapy dogs. So. Okay, so pharmacists. So we here at ETSU, we are so blessed and unique in the fact that we have a academic health science center. So most of these providers, if not all, touch our university or have a program here. So pharmacists, they dispense medicine prescribed by doctors or physicians, dentists, podiatrists, and psychiatrists. They do a lot of patient education, and they need a licensure to practice. So since 2005, they went from having a master's level education to a doctoral level with a PharmD degree. And so with the ACA and with accountable care organizations, pharmacists have played an increasingly important role in the team of healthcare professionals. They really help to bridge that continuum of care. So when someone leaves a hospital or leaves their physician's office and they get their medicine, that pharmacist plays a really crucial part in really helping patients understand. They do a lot of health literacy, helping them understand how to take their medication. In our region, our pharmacists are doing a lot of really interesting things. Community pharmacists are getting involved in helping combat the opioid epidemic as well, in multiple ways. So they're increasingly important as part of our care. Okay, so our next doctoral level health professional, optometrists, what do they work with? Eyes, yeah. They do vision care. They do, they're doctors of optometry. They play a role. What is one health issue, major health issue that optometrists are key in?
Blood pressure.
Blood pressure is one, yeah. So a sign of blood pressure is issues with your vision. What else? Diabetes. Yeah. Vision, loss of vision. They do a lot around chronic illness. Psychologists. So there's two different doctorates in psychology. A doctor of philosophy or a PhD in psychology, or a PsyD, and they work with patients around mental health and behavioral health. Podiatrists, what do they work with? Feet. What is one of the issues that they deal are increasingly important in? Just mentioned it. Diabetes, yeah. So your eyes and your feet are two things that you need to be very careful and keep track of. What about, but they do other things like deformities of feet, including surgeries and corrective devices. What about chiropractors? What do they do? Spine, yeah. So they work with their treatment is through hand manipulation. They help with neuromuscular, vascular problems. They are a doctor of chiropractic. It's a 4-year degree. You need a license to practice, but they do not prescribe medicine and do not do surgery because they are not medical doctors. They're not DOs or MDs. And they believe that the body is self-healing. Okay, so let's talk about our largest group of health professionals, nurses. So before World War I, about 70% of nurses worked in homes or for private paid patients in hospitals. But that has changed, as has our medicine, since World War I. Mr. Youngblood talked about that last week. They're the major caregivers of the sick and injured. They are really there to address not only your physical, but your mental and emotional needs. You need a license to practice, and there's 2 levels that are not at the doctoral level. So you have your registered nurse, which can receive an associate's in nursing or a diploma in nursing, which some hospitals will provide or offer, or a BSN, so a Bachelor's of Science in Nursing. Licensed practical nurse is a vocational nurse. So they typically work under an RN in a hospital or in a setting. What's your percentage or breakdown of?
We have 2 LPNs in the entire hospital. Everybody else is RN.
Yeah, I mean, I think LPNs are not going out of style, but
LPNs can't do assessments, and for reimbursement you need to have assessments in place, and so they can dispense meds and things like that, but it's kind of redundant, so we don't have many.
yeah. Interesting. So we are currently in, and will continue to be in, a shortfall of nurses. So as the average length of stay decreased, the demand for nursing fell originally. But now we have very sick individuals, and so more nurses are needed and more work in this more intensive nursing. And so we have this shortfall right now of about 110,000 nurses, though, if you looked at the number of people we've trained in nursing, we have more trained that are not working than the shortfall. And it's expected that this shortfall will only increase if the current trends continue. And so some of the major reasons for this shortfall are sluggish wages, low job satisfaction, inadequate career mobility, demand for other kind of alternate hospital sites. So do you want to talk a little bit about your nurses?
What you want to know? I mean, we have. Where do you want me to start? I think we actually literally today filled our last spot. We've had open for months. We've had a lot of applicants, but our problem is we need certified rehabilitation registered nurses, people that are willing to go through the additional training. So trying to find the right people. Some people just don't want to go through the extra. But I mean, we have.
How many nurses
great
are?
Great nurses. Oh gosh, we probably got. Let's say we have close to 70 total nurses. So it's around 66, 68, around there. So yeah, it's a big deal for us. I mean, we have on site, we have our nursing department, which also includes a lot of nurse techs. Our ratio is pretty high. Nurse to patient ratio is pretty high, which is good. We have nurse practitioners in house.
Mm-hmm.
So, in fact, our nurse manager is our main nurse manager is nurse practitioner.
Yeah, we'll talk a little bit about that. I've seen more because there's only so far you can go up as a RN. We're seeing increased number of applicants and individuals going into advanced practice nursing. That also allows you to go into case management. We're also seeing a lot just going into case management over your traditional doing rounds. But as a nurse practitioner, you can move up higher in organizations, have more of an administrative role. But this issue of this nurse shortfall is very serious. And so what we're going to do now is take a 10-minute break and then do a nurse staff case study. So we'll come back, and online students, we're just going to pause this until after this activity.
For benefits, you pay their entire annual premium up front. And then if they quit, it's only a prorated amount that you get back. So you lose money hand over fist just from benefits. And if you want to attract employees, you have to have good benefits.
Mm-hmm. Okay. Well, I hope you guys learned something, and we'll put the case up for the online students so they can read through the materials and think through how they would solve this nurse staffing issue. Okay, so we're gonna go ahead and finish. We're almost done. And our class, oh yeah, you guys can move back to your spots. So as I mentioned, we have these two levels of nurses that are RN and LPN, but then we have our advanced practice nurses. So these are nurses with education and clinical experience that move up. They're different specializations. You have clinical nurse specialists, or CNS, and these are advanced practice nurses that are in hospitals, certified registered nurse anesthetist, CRNA. They support anesthesiologists, and that is a very, those programs are very, very competitive. They're very intense, and they're very lucrative careers for nurses. And then the one that you probably hear of and know more about are nurse practitioners. They're in primary care. They are essential from a public health perspective. Public health departments, we just are analyzing some data on providers for family planning, providing, and contraceptive counseling and things around women's health. And from health department clinics, family planning clinics, nurse practitioners across the board are the biggest provider. And those, again, are in primary care. They can practice in all kinds of different primary care settings. And then you have certified nurse midwives. And so they are, we see more certified nurse midwives in other countries. They play a central role in Europe and in the UK. They deliver babies, manage care for moms and babies, and this is before, during, and after delivery. Why do you think we see this more in European or like in the UK versus the US?
You have a more like communal atmosphere.
Yeah, so it's more communal. Why else? So most European countries have universal health care. And what is one of the ways that you control cost in universal health care?
Decreasing hospital stays and usage.
Yeah, and so they have global budgets. So there's like, this is how much we're going to pay. This is how much of our GDP that's going to go to healthcare. So if you only have a certain amount, nurse practitioners are cheaper than a physician. So they've stayed in and have continued to be a model. So midwives used to deliver all the babies, and in the home setting. Then hospitals became more popular, and then we kind of moved. There's this very fascinating transition of delivering babies and mother care from this home setting into the hospital. So these other physician extenders are non-physician practitioners beyond just the different advanced practice nurses. Would be the physician assistants. So really when you think about physician's assistants and nurse practitioners, including certified nurse midwives under there, that they practice in many ways similar to physicians, but do not have an MD or DO. So, and nurse practitioners and physicians, they are kind of like, they have different philosophies. So physician assistants are more from the medical model, and nurse practitioners are from that nursing model. So PAs are part of the healthcare team. They work in a dependent relationship with a supervising physician. They're licensed to do medical procedures under the supervision of a physician. And that relationship can be on-site or off-site. And those relationships for both nurse practitioners and PAs are regulated by the state. So there's some of the work that's being done that we're looking at are state level policies to increase the number of nurse practitioners that one physician can oversee, because that can really increase access in communities. So if you have one doctor and they can oversee 3 nurse practitioners instead of 2, that increases quite a bit across, a state. So same with physician assistants. That's a state-regulated number of PAs to physicians. So the duties for PAs include evaluation, monitoring, diagnostics, therapy, and referral. And they, again, follow more closely the medical model and focus on disease. Nurse practitioners, they follow that nursing model with health promotion and education, because they, again, are trained in those different kind of philosophies. Okay, our next group are our allied health professionals. We don't have a RETI in our class this year, so we don't have a allied health professional in our midst, but this includes many health-related areas, and it constitutes about 60% of the healthcare workforce. And there's 2 broad categories. We have technicians and assistants, and those are typically individuals in 2-year kind of programs or less, and post-secondary education. And then we have our therapists and technologists, and so of course this is more training and advanced training. 2 areas that we have, again, since we have the Academic Health Science Center here, are PT and OT. So what does PT do? What is OT versus PT, I guess?
Occupational and physical therapy.
Yeah, so you have occupational therapy, which is OT, and physical therapy, which is PT. So what do they may seem similar. They have therapist in their name, but what is their focus? What's the difference in their focus?
I was gonna say OTs are more kind of workforce oriented, and that's a major concern. It's like bringing someone back into the workforce.
Mm-hmm.
And PTs are more rehabilitation.
Yeah. So that's spot on. OT, improve your ability to perform your daily tasks. So get back to work if you have a issue on the job, or work on those activities of daily living, things that you need. PT, yeah, it's usually from a rehabilitative place. So if you've had a stroke, if you've broken a bone, if you've sprained something, yeah. So PT kind of is focused on movement dysfunction. Okay, and then our last group of healthcare professionals are the health service administrators. They're employed in various levels of organizations, both in public and private. They manage integrated delivery organizations that are very complex. So there are kind of this tier of manager up to leader. And so kind of at your top of an organization are your leaders who are in charge of the long-term success of organizations. So these are your directors, your C-suite folks. You have your mid-level, which are the head of major service centers, or large departments or units within a system. And then you have your entry and level administrators, who are assistants to the mid-levels or oversee the smaller departments or units. And the education are varied, but individuals who have any of these degrees or any combination work in administration. So Mr. Youngblood has his MHA, but we have lots of individuals who work in the healthcare system and in the public health administration that have MPHs, MBAs with a concentration in healthcare. One I don't see as much is MHSA or MPAs. You don't see as much of those. But I think we're seeing a greater and greater proportion of individuals working in administration that have MPHs as well, in part because of the Affordable Care Act and ACOs and this kind of blurring of the lines between public health and healthcare and population health. And with everything we talk about, there's plenty of challenges that are facing you all as you think about and move into this field. And these are things that will sprinkle in through the rest of the semester. Financing and payment structures, working with decreasing levels of reimbursement, but also being charged with having high quality and high patient experience. The pressure of uncompensated care. We saw a decrease in people who were uninsured. That's kind of flipped up a little bit. We're not sure where we're going to land in the end, but uncompensated care is always going to be an issue. Along with financing is those demands of your different public and private payers. You're going to need a mix of both. You can't survive without either of those. And that payer relationship is really important and complex. New policy developments. I mean, since we've been in the field, fee for service to pay for performance just that shift. And then new guidances, your new coding, the ICD, like there's just always changes. And then the changing competitive environment, you're going to see more of what we saw happen here, where it makes more sense to merge or become, bedfellows with your competition, because the enemy is better than the unknown. I think that's what we found with this merger, is that there's just this competition for those patients, and it's going to be ever increasing. We'll talk more about mergers and acquisitions, but it's really changed the landscape. And you have to do this while managing integrity throughout it all. So exciting times. And then just a little bit about the global health workforce challenges. 57 countries, mostly poor, are countries predominantly in sub-Saharan Africa are facing workforce crises. So this workforce issue is not unique to the U.S. We're seeing with the change of, like we talked about this in the intro health admin course, that people are living longer in the U.S. because we're not dying from infectious diseases, but we're living long enough for our behavior to catch up with us, and we're having chronic illness. Due to globalization across the globe, life expectancy is going up, but that changes the need for primary care for those chronic care. And then, the benefit to us is these international medical graduates, but by by the flip side, and international medical graduates are not just coming to the U.S. They're going to Australia. They're going to pretty much all of the industrialized world. We're taking graduates from other countries, and what does that leave? A country. It's like they're the world's rural and like rural communities, right? They're the ones that have a loss and have this maldistribution in their countries because people want to come to the U.S. and other industrialized countries to practice for all the reasons we talked about. So that creates this imbalance. So in the places where the need is the greatest, they also have the greatest challenges with their workforce. All right, so there has been, like the ACA has done quite a bit around trying to get increasing the numbers of medical residents and nurses. There is funding to increase monies for residents and programs to help increase and incentivize people to go into nursing. And part of that is because it was necessary. When you insure more people, you're going to have providers to care for them, because really there's a strain on our system related to those newly insured individuals. And we're seeing the Affordable Care Act, multiple different parts of it, really emphasize the medical care delivery by teams. Even if you got rid of ACA tomorrow, that's not going to change. Like this team approach to healthcare, so including all of the PT, OT, pharmacists. I mean, when you talk about bundle payments and all these different models, they include a more continuum of care and a wraparound services of all the different providers. And the ACA also has increased loan forgiveness for individuals who choose to work in certain areas. So you'll read about programs that incentivize people to go to rural and isolated communities, and the benefit is you practice there for a certain amount of time. Your loans get forgiven. That includes physicians, pharmacists, and others, psychologists, different parts of the healthcare field can take advantage of those opportunities. Okay, that's all I have for you guys. So we will see you in 2 weeks. Don't come here next week, and happy studying.